need to move to our last session, which is, as we said, best for the last. It is Professor Dr. Nesrine Refai, Professor of Anesthesia and ICU and Pain Management, Qasr Al Aini Hospital, and one of our eminent colleagues sharing in more than anesthetic journal and more than one workshops.
We're going to talk about obstetric anesthetic management for post-COVID-19 patients. First, we have to know some few definitions. Post-acute COVID-19 or long COVID is the persistence of symptoms 3 or 4 weeks after the onset of acute COVID. This syndrome is divided into two periods: ongoing symptomatic COVID, which persists 4 to 12 weeks beyond acute COVID, and post-COVID syndrome persisting 12 weeks beyond the acute attack. The mechanism of post-acute COVID is not known, but it could be due to virus-specific pathological changes, inflammatory response to acute infection, or a sequelae of post-ICU illness. And this syndrome can occur even after mild initial COVID, so it hasn't to be a hospitalized patient or critically ill. COVID is known to cause a multi-organ system effect. It's documented in most body systems. Even autoimmune conditions can occur after COVID-19. The post-COVID conditions include cardiopulmonary, neurological, general symptoms, ENT and GIT symptoms, and even psychological disturbances. There is some management consideration for a patient in the post-COVID symptoms. It's a guide us to do for anesthesia. We have to review the neurological system. If we find peripheral neuropathy, then take care during giving neuromuscular blockers and quantitative reversal of the blockers, and we may think about avoiding regional anesthesia for medico-legal purpose. Cardiovascular palpitation or chest pain, this needs perioperative ECG, transthoracic echo, and cardiac consultation. Pulmonary functions, if we have restrictive lung disease, avoid general endotracheal intubation and go for regional, and take the consent of the patient that she may need post-operative ventilation. Hematological conditions, especially hypercoagulable state, needs pre- and intraoperative and post-operative thromboprophylaxis, and it's beneficial to use the enhanced recovery protocol to facilitate mobilization post-operative. Now we come to the real scenario. It's the cause why I thought about this lecture. The senior registrar told me that we have a list tomorrow with a patient coming for cesarean section. She was admitted to the hospital 2 weeks ago with acute COVID and high fever, and she was isolated and treated, and now she is okay, and the swab today, the PCR is negative, and they are coming for cesarean section tomorrow. So I didn't know what to ask about. Should we reassess the patient? Should we have the operation with the full PPE in the isolation theater or in the elective theater? So as we know, post-COVID can occur during pregnancy, and especially pregnant women with the physiological changes with pregnancy are more prone to respiratory infection, because the large uterus expand upon the diaphragm, pushes the diaphragm up, leading to lung, limiting lung expansion, and it's a sort of restrictive lung disease and upper respiratory tract edema. One of the large researchers have included women in the some of them they were all had COVID. Some of them were pregnant and others were not pregnant, and they compared the two groups. They found there is a high availability of COVID in pregnant women more than the non-pregnant, and the pregnant women are more prone to critical illness, hospitalization, and mechanical ventilation. Actually, pregnant women are 1.5 times more likely to be admitted to ICU, and they are at increased risk of complication of pregnancy, preterm birth, and cesarean section. But the evidence of vertical transmission of COVID is extremely limited. Vertical transmission means a transmission of infection from the mother to the fetus, which occurs either in utero through the placenta or intrapartum during vaginal delivery or cesarean section, or postpartum as a part of droplet respiratory infection. Few weeks ago, all researchers said there is no evidence of transverse infection, but transmission of coronavirus. But just few weeks ago, the researchers found the amniotic fluid in the placenta of the infected mothers. Few of these mothers had PCR positive for amniotic fluid and placenta, which means there is possibility of transmitting infection to the fetus, and the neonates were affected. But these were only 3 or 4 cases among thousands of cases. Signs and symptoms of COVID and post-COVID are almost the same, but the most common during pregnancy were cough, sore throat, shortness of breath, loss of taste and smell, and some of the symptoms of normal pregnancy. So almost all pregnant have nausea and fatigue and dizziness. That's why the diagnosis of COVID in pregnancy may be delayed, because there is overlapping between the symptoms of pregnancy and the symptoms of COVID. Timing of delivery, COVID infection itself is not an indication for delivery, and COVID, if it occurs early in pregnancy, in the first or second trimester, there is no alteration to timing of delivery. But if it occurs in the third trimester, we just postpone delivery until we get a negative test. A cesarean delivery should be based upon obstetric indication, not COVID itself. Cesarean is only indicated for pregnant women with severe respiratory distress syndrome. This is the only indication. Decision making regarding delivery depend on the gestational age, comorbidities, the degree of hypoxemia and rate of disease progression, response to therapy, fetal well-being. For example, a pregnant woman between 23 to 34 weeks, we have to detect the antenatal corticosteroids. And for example, if the mother at the 14th day of symptoms and she's not intubated and is doing well, she might improve with therapy. In this case, we don't have to go for cesarean, just give the fetus choice to delay delivery. But if we have another scenario of patient, for example, at the 7th day of the start of symptoms, and she's already intubated now, this means most probably she will get worse. In this case, we deliver the fetus to save his life. Vaginal delivery for a patient with COVID, we have to review platelet count, because 1/3 of patients with COVID have thrombocytopenia. Neuro-axial anesthesia is recommended for these patients, especially epidural, and we have to initiate epidural early. So at any time, if we have to shift for cesarean section, we can just top up the epidural and convert to surgical anesthesia. Nitrous oxide is a kind of debate. Actually, some hospitals all over the world said that we have to suspend the use of nitrous oxide with suspected or confirmed COVID. While in UK, the Royal College of Gynecology, together with Obstetric Anaesthesia Association, recommended using Entonox for vaginal delivery to relieve pain, but use single patient microbiological filter. Preoperative assessment should include clinical history of suspected or confirmed COVID, nature and severity of symptoms, timing and duration of symptoms, and other comorbidities. Physical examination, we have concentrated on functional assessment and investigations, estimation of the effort tolerance, breath holding time, ambulatory oxygen saturation is very important. 6-minute walk test should be performed for all patients before cesarean section. Cardiopulmonary and nutritional status should be assessed and optimized if possible, and normal labs. But what about PCR? Actually, PCR test can remain positive even after recovery, even up to 90 days of the onset of COVID. So we don't depend on it. It can be misleading. But if the patient came for a cesarean section after 90 days of COVID, for example, the patient had COVID in the first or second trimester, and now she's full term and coming for delivery, in this case we can repeat PCR 3 days before surgical procedure, because there is a possibility that she got another infection. Specific consideration for medication for patient with COVID during labor or postpartum period. Oxygen. Overall, the use of oxygen for fetal intubation for the fetus is controversial, because we use oxygen for the patient during face mask or high flow nasal oxygen, and both procedures are aerosol procedures, so they transmit infection to the OR and to personnel. Nitric oxide, as we said, is a kind of debate. PCA, intravenous PCA with opioid, as fentanyl or remifentanil for labor analgesia. This case, we have to consider the risk of respiratory depression, so it's better to avoid using PCA with opioid. Non-steroidal anti-inflammatories are again a kind of debate, because non-steroidal, as we know, have ACE2 receptors which combine to the COVID virus. So it's said that ketorolac and other non-steroidals will augment the infection and increase the infection. So and increase the renal affection for the patient. So it's better to be avoided. While some authors say it's better to use non-steroidal, replacing the opioid to avoid the respiratory depression. Regarding carboprostim, which is the first choice for the patient with uterine atony and postpartum hemorrhage, but this drug causes bronchospasm, so in case of COVID, it's better not to use carboprost, and we can instead use oxytocin or methadone. Magnesium sulfate, as we know, we use it for patients with PIH, but keep in mind that for COVID patients, these drugs have central nervous system and respiratory depressant effect. So it's better to avoid using magnesium sulfate, except in extreme indication, patients with severe PIH, and we need to give magnesium sulfate to prevent seizures. In this case, we'll use magnesium sulfate in a dose of 4-gram bolus dose, and that's all. We don't give initial bolus and infusion. What about emergency cesarean section? Actually, emergency cesarean and exploratory laparotomy are the most likely emergencies that we face with COVID patients. Regional anesthesia is preferred technique when feasible because it has several advantages, as we know. But what type of regional? We can use spinal for cesarean, or epidural, or combined spinal epidural. And even the most recent research are talking about category 1 cesarean section. As we know, category 1 means it's emergency cesarean section, and we need to deliver the fetus within 30 minutes. It's the decision to delivery time within 30 minutes. For these patients, we have a technique that started 2003. It's rapid sequence spinal. They call it rapid sequence spinal. In this technique, it's used for category 1 cesarean section, but this technique is not an individual technique. I can take decision to perform rapid sequence spinal for the patient. It's a system that should be established in the labor unit and OR. So when we take decision of cesarean section, we pre-oxygenate the patient from the start. Even in COVID patient, and especially with COVID patient, we have to do pre-oxygenation from the minute we took the decision. And we prepare the OR for both spinal and general anesthesia with all drugs and all equipment ready. And one of the team is assigned to put intravenous cannula and monitoring while they are transferring the patient to the OR. And the anesthesia should be ready in the OR. We don't scrub. We just wear the sterile gloves with no touch technique, and we use no touch spinal technique, which means the most expert anesthetist should perform the spinal without even feeling the vertebral column and detecting the space. He just omit the local anesthetic. We don't give local anesthesia. We go for spinal, one trial or at most 2 trials. If I'm sure that there is something wrong, I can correct it in the second trial. And we give local anesthetic with or without fentanyl. 25 mic fentanyl with local anesthetic. But in this case, in any other spinal for cesarean section, we limit the local anesthetic, the heavy Marcaine, to just 2 milliliter or 2.5 maximum. Local anesthetic or local anesthetic with opioid. But especially for this patient, the rapid sequence spinal, we can increase the dose to 3 milliliter. The whole volume can be increased to 3 milliliter. And we can, if we are sure that the anesthesia have started and the patient already have numbness and loss of sensation, at T10 we can ask the surgeon to start rapidly, even before reaching the surgical anesthesia at T4. General anesthesia for emergency cesarean, in case of failure of the spinal or regional anesthesia, we go for emergency CS under general anesthesia. And it can also be used in patients with decreased cardiopulmonary reserve. Induction agent, propofol or etoposide are fine for the circulation. Rapid sequence induction with rocuronium or saxamethonium. But for COVID patient, we don't like saxamethonium because these patients, even the post-COVID period, they have myalgia and rhabdomyolysis and loss of muscles. So it's better to avoid saxamethonium because in this specific patient, it may cause fatal hyperkalemia. Use high FiO2 until fetal delivery. Epidural combined with general is very good choice for postoperative analgesia, and we can use opioid, short-acting opioid as fentanyl, but we don't give the full dose. We don't give 200 or 300 mic from the start. In a COVID patient, we just give a top up of fentanyl to avoid sedation at the time of extubation, because at the time of extubation it should be awake. in this special patient. Post-operative care, whether to shift the patient to the ward or to ICU, it depends on the availability of oxygen supplementation and the post-operative condition, close monitoring of hemodynamic and respiratory deterioration. Some patients may need post-extubation CPAP or high-flow nasal oxygen, and good post-operative multimodal analgesia. TAP block is good. Post-operative thromboprophylaxis is a must. Then we have to discuss the thromboprophylaxis in these patients. As we know, pregnancy is hypercoagulable state, and COVID-19 infection may increase coagulopathy. That's why the National Institute of Health have published recommendation for COVID-19 pregnant patient. They recommended that pregnant patient hospitalized with severe COVID-19 should receive prophylactic anticoagulation. All pregnant hospitalized patients with COVID continue on thromboprophylaxis even 10 days following hospital discharge. We either use unfractionated heparin or low molecular weight heparin. Unfractionated heparin is preferred for the patient near time of delivery, patient who could deliver within 2 to 3 days, because it's easily to be reversed with protamine. If the patient is not expected to deliver within a few days, we can shift to prophylactic low molecular weight heparin. So in the COVID and post-COVID patient is most probably on antithrombotic and or antiplatelet. What to do for as precaution for anesthesia? If she's on low dose aspirin, it's safe and there is no special precautions. If she's receiving low molecular weight heparin prophylactic dose, we stop it 12 hours before cesarean. If she's receiving therapeutic low molecular weight heparin twice daily, we stop it 24 hours before cesarean. A few cases of high-risk patient may receive clopidogrel or Plavix. In this case, if the patient is a high-risk cardiac patient with heart failure or cardiomyopathy, the clopidogrel can be stopped 5 days before cesarean and then continue post-operative. Low-risk cardiac patient with dual antiplatelet should be stopped 7 to 10 days before cesarean. But patients with coronary stent may receive aspirin and clopidogrel. It's a dual antiplatelet therapy. In this case, we have only with stent. We have to continue the dual antiplatelet, and in this case, we have to avoid regional anesthesia, and we go for general anesthesia. Direct anticoagulants are not routinely used during pregnancy, except in very few cases because it's not safe yet. For example, this patient on oral anticoagulant should discontinue 24 to 48 hours before surgery or cesarean section, but should be stopped 72 hours, which means 3 days before neuroaxial technique, and this is very important. Of course, if you have available thromboelastograph, it's the best that can provide coagulation status of the patient. But if after all these precautions, we still have severe intrapartum or postpartum hemorrhage, and we have to administer fresh frozen plasma to stop the effect of the anticoagulant. Postpartum hemorrhage is common in COVID pregnant patient, and in this case, as we said, we don't use carboprost, we can use oxytocin or methergine. Tranexamic acid, tranexamic acid has pulmonary and prothrombotic manifestations, and the same goes for COVID-19. So the tranexamic acid can increase bronchospasm and increase clotting for the pregnant patient. Although we avoid using tranexamic acid for asthmatic patient, but for COVID patient, It's written in literature that we may consider tranexamic acid for postpartum hemorrhage, but it's still a kind of debate. We have to weigh the risk against benefit. Prognosis, the overall prognosis of these patients, the largest single database study of pregnant patients with COVID was published in the JAMA Network 2021 at August. They recommended that women with COVID had a peripartum death rate of 0.1%. The death rate and ICU admission is significantly higher among COVID pregnant patients than the normal pregnancy. Increased need for invasive ventilation and ICU admission, and they have severe symptoms and at higher risk for cesarean, preterm birth, PIH, and postpartum hemorrhage. And the worst outcome is, were in pregnancy with obesity, hypertension, or diabetes. Any questions?
Thank you, Doctora, Professor Doctora Nesrine, for your very, of course, informative lecture. And we open the field now for questions for Doctora Nesrine. Any questions? Can I ask you a question, Dr. Nesrine? Of course, يعني, the lady is pregnant and everything, and she's going to deliver, but her fetus is now يعني, full term, for example. So do you think sometimes we screen the patient post-COVID before anesthesia by doing a CT chest? Do you think we should do that or make it like a routine or put it in the protocol for anesthetizing cesarean section?
For post-COVID, if the patient has history of COVID during pregnancy, it is accepted. If she's already has COVID, it's again indicated that she should have CT chest, and we take the precautions to for the fetus. So we put apron over the abdomen, and we take shortcuts, and we limit the time of exposure to radiation. And it's written in the literature that there is a maximum radiation point. It's the unit, I don't remember the unit now, but we found that X-ray and CT, the normal exposure for investigations does not reach this critical limit of units of radiation. It's called a millirad, I think. So it's usually less than 5 millirad. So there is no risk for the fetus. So even for traumatized patient, we can do the necessary radiology.
And يعني, this is very nice. We heard it from you, and that you are telling us that it is already confirmed in the literature. Because I'm thinking not only post-COVID, if a patient, like she's really in the course of the infection now, and she just entered into labor, like an emergency cesarean section should be done for her. So again, I think if we make a preoperative CT for this patient, at least we can categorize her like risk, high risk, and we can take the patient on intubated. We will not extubate after cesarean, and she can go. I mean, we can decide by the aid of the CT, if it is so bad, we can take her intubated after her cesarean section to the ICU, for example.
Yeah, that's
it's good that, it's good that we can. It's so a very important.
Don't be afraid. You can go for CT or X-ray. Actually, I've given anesthesia to one of our colleagues who had a car accident, and she was pregnant in second trimester, as far as I remember, and she had fractured femur, and surgeons had to operate and use the image, and they
Yeah.
had to use image several times during operations. So I told them it's okay if it's emergency and you have to fix the fracture now. You can use image, but limit the exposure and take precautions for the fetus. And that
Yes.
was done successfully.
Another thing, if the patient is really in COVID or early post-COVID and she is going on the routine, يعني in severe cases, the routine post-COVID therapy is to continue the anticoagulant, even if oral, like some people take it like 3 months post the COVID.
Yeah.
So at that time, again, this will be our challenge. So for giving, I mean, regional for the cesarean, or better, it would be GA. I mean, this is a debate because, again, this patient will be anticoagulated. So what is your opinion about that? I mean,
Um, um,
PPT and INR, platelet and count
the
would
thromboelastic
help.
graph is fine. Actually, it's not very helpful because for the oral anticoagulant, the reversal, the antidote for the anticoagulant is present, but it's not readily available, and we can't depend on the coagulation profile because the INR and prothrombin and all these investigations do not detect the effect of the oral anticoagulant, not quantitative or qualitative. So I can depend on them.
Yes, thank you very
That's
much for
why we have to
illustrating.
take care
Yes,
when to stop them. Or shift, we
okay,
can even bridge, shift the patient to
bridge.
Clexane or heparin and stop it 6 hours before the operation.
Yeah, you can bridge if it is like elective. But if, as we said
Yeah.
again, the scenario is worse
And
and
if it
she
is
is going on,
emergency, so we can go for
yes,
GA. But tell the patient
yes,
that most
excellent.
probably she may need post-operative ICU and ventilation.
Yeah, I opened this point because I need all the audience to hear that from you. Thank you very much, Professor Dr. Nesrine. And if anyone would like to have a question,
Um, I think Ahmed Samir raised his hand.
Everybody is happy by this time now. So I think it's time to conclude our webinar, Dr. Asmat.
yes. Okay.
Thank you.
I would like again to thank all our colleagues and our guest, our honored guest, Professor Dr. Gamal Lotfi, for sharing with us. Maybe this is the first time, I think, Dr. Nesrine, that the Scientific Obstetric Day have a guest from outside. And it was a very nice presentation from all of us. I would like to thank again the interactive session team for anesthetizing or يعني
It was very nice
this
case,
patient,
actually.
yeah, and
I recommend they
putting the
publish
present.
it.
Yes, yes,
It's a
it's very,
very
very
nice
nice.
case reported.
Yeah, and actually we have many capabilities in the theater of the OB-GYN in Qasr Al Aini Hospital. But again, we're not like a tertiary يعني hospital specialized in this special cases, and this case was really very grave in the disease. So I hope everyone enjoyed our sessions, and thank you for everyone. Thank you for Dr. Saad. Thank you for Dr. Magid. He was the
Thank you,
link between
everybody.
us and Dr. Saad. And of course, we were honored by the introduction with our Professor, Chairman of Anesthesia, Dr. Mohammed Abdul Thank you, everyone. And thank you for the attendees for the attendance and even for the questions.
Thank you, Dr.
And
Saad.
would like to meet you. Yeah. Thank you very much, Dr. Saad.
Thank you very much,
Thank you.
Dr. I really
Actually,
enjoyed the
I
night.
just want to give one comment. Honestly, Dr. Saad, I'm a member of Education Committee of World Federation Society of Anesthesia, and we are publishing the our journal, the update. It's a free journal, peer-reviewed, and assigned to write an article about remote learning,
Fantastic.
the online learning, and so I found that all points for successful remote learning is really present in mega course. I even
you so much.
have written
Excellent.
mega course as a reference.
Oh, thank you so much. I would be so
Excellent.
grateful.
I told them we already share the remote learning, and it's
Okay.
attended by thousands.
I would be so grateful to you if I have a copy of that reference, please.
Sure,
You
it
know.
will. It's we are reviewing the articles now. It will be
Thank you so much.
launched and published online.
That's so kind of you, Prof. Nesrine. Thank you so much. Thank you.
We are